We are live on YouTube also.
It's 7:50. Amit, shall we start?
Good. Evening, everybody.
Hello, Braja. Good evening. Amit, let's start, I think.
Yeah. Good evening, everybody. It's a privilege to have such a esteemed faculty and so many participants with us. We are about to begin our All About Sepsis, which is a part of NNF action plan for the year 25-26. After a lot of planning, this has come over. It is a final result of a lot of hard work of many people led by Dr. Sridhar, Dr. Abhay Matthew, and we are very thankful to them for giving this excellent program to NNF. And as we know, sepsis is a big problem for all NICUs. It's a menace for treating pediatricians because once the baby is coming out of prematurity, he acquires sepsis. Rates of sepsis are very high, almost 30 per thousand live births. And looking at the number of births, we can imagine what is the magnitude of sepsis which is there in our country. Then about 20% of all mortality are related to sepsis. So if baby is born prematurity, preterms are more likely to have sepsis. LBW are more likely to have sepsis. All babies who are ventilator are likely to have ventilator-associated sepsis or pneumonia. So all such babies are, despite our excellent work with surfactant, ventilation, preterm care, the scourge is neonatal sepsis, and we lose many of our babies due to sepsis later. So how do we diagnose early? What are the organisms? How do we detect as soon as possible? How do we confirm with the microbiological and DNA or RNA genetic tests? This is all which we will cover in this module, which is there. Now, more details about the module will be coming over by our great Dr. Sridhar Santanaman, who has pioneered this program or this workshop and CME on sepsis. I would request now our President, Dr. VC Manoj, to please give his essential take on this phenomenal course of NNF all about sepsis. Over to you, sir.
Dear esteemed colleagues, it is with great pleasure that I am again extending a warm and heartfelt welcome to each and all of every one of you for All About Sepsis, a comprehensively and timely course developed under our action plan, guided by our central mission, reaching the unreached. As Amit was mentioning, sepsis continues to be one of the most formidable challenges in neonatal care, and addressing its early detection, timely intervention, evidence-based management, all these are not just vital, it's life-saving. And this course is going to reflect our collective commitment to empower practicing pediatricians and aspiring neonatologists with up-to-date insights, sharpen clinical judgment, and practical tools so as to protect the lives of our most vulnerable patients. Friends, through this course, we will explore pressing questions such as when should you use antibiotics and when you should not? If necessary, which antibiotic is most appropriate? Why does withholding use of antibiotics sometimes yield better outcomes in NICUs? What are the proven strategies to prevent sepsis? How do we tackle highly resistant infections, including fungal pathogens? How should we manage outbreaks effectively and efficiently? So it's a complete course, and I would encourage all of you, all the delegates, to feel free to ask all the silliest of the doubts. They think they are very silly, but they are very, very important, and they're going to make the foundation strong in your practice. With all these, we aim to foster a deeper understanding, promote standardized evidence, informed care, so that we are able to bridge the gap between science and practice across different clinical settings. What is evidence-based in one part of the country will not be evidence-based in another part. That is a problem, the complexity of the solution. That's what we need to understand. That's what we want you to understand from this course. So that is why understanding the basics is very important. I may use something as my strategy, which may not be relevant for you if you're working in a different setting. We are really humbled to have more than 1,000 delegates who are registered for this course. Friends, your participation stands as a testimony to our shared dedication to improving health outcomes for neonates and children across the country. As you know, today is the first live session in this course, and we will complete it after 4 weeks on 18 July with a final panel discussion. Let us embrace this course not merely as an academic exercise, but as a spark, one that ignites collaboration, inspires innovation, and strengthens our resolve to make high-quality neonatal and pediatric care accessible, bridging the gap between science and practice everywhere. Let me extend my sincere gratitude to Dr. Sridhar Sandhanam and his team, who instantly agreed when I mentioned them about this, and for their leadership in designing this outstanding curriculum. My heartfelt thanks also go to our distinguished faculty for the generously contributing their time and expertise. And of course, the plan needs to be executed. So a special note of appreciation to Dr. Abhay Matthew and the entire sepsis committee team for the meticulous efforts in bringing this initiative to life with such excellence. So once again, wishing each and every one of you an enriching and impactful learning journey, so that at the end of 18 July day, we will be much, much more wiser in managing this very strange dynamic problem. Wishing you once again all the very best. Thank you. Now, may I request our course director, Dr. Sridhar. Before that, may I request our president-elect, Dr. Lalan Bharti, to speak a few words. After that, we'll hear more from our course team. Lalan, you're muted.
Thank you, Dr. Manoj. Thank you very much. Good evening, friends. It is indeed an honor and privilege to be part of the inauguration of this important program. I sincerely commend and congratulate our visionary president, Dr. Manoj, and all the faculty members, especially Dr. Sridhar, Abhay, for this timely initiative on neonatal sepsis. As said by Dr. Manoj and Amit, neonatal sepsis has been a major challenge in neonatal care. While we have excellent evidence-based guideline, courses on sepsis, prevention, diagnosis, treatment, and antibiotic stewardship, but these are not being fully implemented at the grassroots level. That's what we are planning through this program. So bridging this gap is a challenge, and we must address this issue together. Alone, we can't do anything. So under the able leadership of our president, secretary, and with the commitment of this expert group, I am confident this initiative will make a significant dent on the neonatal sepsis and eventually neonatal mortality. I assure you all, the mission on sepsis prevention, treatment, and antibiotic stewardship will remain a priority during my tenure and beyond. With this, my best wishes for the success of this program. So let us continue working together for the cause of newborn. So once again, thank you all and best wishes.
Thank you, Lalan. Now, in request our course director for this course, who was the brain behind the finer details of designing this course, Dr. Sridhar Sandhanam, to give an outline of the whole course. Over to you, Sridhar.
Sure. Thank you very much, Dr. Manoj, Dr. Lalan Bharti, Dr. Amit. Actually, I think Dr. Manoj has said most of the things that need to be said. All of you know that sepsis is a very important problem. This is something that we meet in our day-to-day life very, very often. Antibiotics are the drugs which are most commonly used in the NICU apart from multivitamins. And yet, I always keep saying, this course I've been running in my institution for the past 2 years, any fellow or any DM candidate in neonatology can reel off the indications for starting ECMO, in spite of the fact that I think 99% of us are never going to work with ECMO in our lives, possibly, right? But I doubt that anybody would be able to tell us the difference between gentamicin and amikacin. I've asked many of my DM students, and it's very few people who can actually tell this. And that's rather thing. So sepsis, it seems as if everybody is an expert on sepsis and nobody is an expert on sepsis. Sometimes we seem to know everything about sepsis, and then when we actually try to manage a baby, we don't seem to know anything about sepsis. And so we designed this course, as Dr. Manoj said, we it goes through the whole thing. This is what we were doing. And when we actually run the program, we also have a lab visit, which unfortunately, because of the online, we are not able to do. So this will be about use and misuse of biomarkers, how to use diagnostic facilities, how to treat, how to have antimicrobial stewardship, how to prevent resistance, how to manage highly resistant infections, including fungal infections, and outbreak management, which I think quite a few of us meet once in a while. And I think there was a thing last time saying that we are sort of excluding viral infections, and therefore, though it's called sepsis, we have included viral infections also. And finally, looking after your unit. So I hope that it will be a sort of an all-round course, and at least it will provoke thought, and it might lead to better practices among at least a few people, and possibly help all of us to learn from each other. right? So I hope every one of you benefits by this course over the next 8 weeks. Like I said, there has been a lot of work, like Dr. Manoj said, from my All About Sepsis faculty also, some of whom are there on the as the panelists here, and all the faculty have put in a lot of work. So I hope everybody will benefit. Thank you.
Thank you, Sridhar. Now, I would request our the committee coordinator, Dr. Abhay Matthew, he was the one who was going behind and executing each and every fine point. So, Abhay, just please explain the course outline and introduce the faculty for the course and how it is going to be done.
Respected Chair, NNF National President Dr. Manoj, Honorable Secretary General Dr. Amit, President-elect Dr. Lalan, senior faculties and dear fellow doctors attending online. Good evening to you all. At the onset, I would like to thank the Central NNF led by Dr. Manoj for entrusting me and my friend Dr. Nelvi with this job of coordinating this module. I am thankful to each of the committee members, the faculty, and the supporting team from the NNF office. We can proudly say that the number of registered participants is almost reaching 1,000 across from all states of our country, from rural to urban areas, from Kashmir to Kanyakumari, and from Assam to Mumbai. I'm not taking much time since I am sending all communications through WhatsApp and keeping all this large number of participants updated. Just I would like to tell the topic of this first module: rational practices to prevent late onset sepsis and NEC in the neonatal period. Today's speaker needs no introduction, and he is a great teacher and researcher. Sepsis is his passion. No antibiotics is his slogan. I have great pleasure to introduce Dr. Sridhar Sandhanam, Professor of Neonatology at CMC Vellore. Sarah has taken great pains, and this module itself is his pet project. Also introducing the two moderators for the session, Dr. Brajagopal Ray from Kolkata and Dr. Tanushree Mukherjee from Mumbai. Wishing all the participants a happy learning, and I am not standing between the great live lecture coming in the few minutes, and wish you all a happy learning. Thank you, JNNF.
Thank you, Abhay. Now, the committee co-chairman is Dr. Mamta Jaju, another faculty. So I would request to just register the vote of thanks, and then straight away we will go on to the lecture.
Thank you. So, Dr. V.C. Manoj, President-elect, Dr. Amit Upadhyay, Secretary, and President-elect Dr. Lalan Bharti, and all other faculty members. So it's a very, very important module, and I want to congratulate NNF India for launching this response which has been seen, and we all know that it is the most important cause of mortality, and the way we are facing the multi-drug resistant infections and other problems in the neonates. So thank you so much, Dr. V.C. Manoj and Dr. Amit Upadhyay for launching it, Dr. Lalan Bharti for supporting, and all the committee members, especially Dr. Abhay for working so hard, so coordinating with everyone and announcements and the messages you are sending and doing a lot of work. So thank you to you also. And I am privileged that I'm working with Dr. Sridhar sir, that I just heard that he is a wonderful teacher, and I'm grateful that I will also listen to him. So every participant, I want to just say that you are lucky that you are having such an excellent faculty for this workshop. So enjoy this and use this, and please apply this in your day-to-day practices and save our newborns. And thank you to everyone who is participating in this workshop, and hope you will enjoy it. Thank you so much. Thank you.
Thank you, Dr. Mamta. So before we go on to the session, let me just again reiterate a few points. First of all, dear participants, do interact. You have to ask the silliest of the doubts. What is the practice that you're doing? You can illustrate that, and then this is how it is different, and how am I different, and all. Get your basics cleared. That is the first thing, because now We know that with after the human microbiome project and all, no, like we are talking about zero antibiotic, NICU feasibility and things like that. So it's a different way, but then most of the things what are said in science are not brought into practice. That is where the role comes. Please, so we will have 2 lectures every week. And I would request all of you to attend all the lectures and interact with the faculty at that point. And finally, we will have a common panel discussion at the end. In addition, the learning management system of the NNF will help guide you through the rest of the course. Now, we have 2 great neonatologists of the country, Dr. Brajagopal Rai from Kolkata and Dr. Tanushree Mukherjee from Mumbai. Both of them are going to take us through this session. So over to you, Braja and Tanushree.
Thank you very much, and good evening to everybody. We're already 10 past 8, so rather than wasting our time, we'll straight away go to the lecture. Just I wanted to say something. Dr. Sridhar, yeah, he's one of the few neonatal pundits, I would say pundits of our country. And our NNF is very proud to be associated with him. And thanks to Dr. Manoj, this wonderful and brilliant idea. So we'll go to the session. Before that, I'll ask Dr. Tanushree to say a few words. Thank you.
Hello, good evening, everyone. No, I think we are so privileged to hear from Sridhar sir today. And I'm sure all the delegates will have lots of questions. So put your questions on the chat box so that once sir's this session is over, so we will have more time for the interaction as well. Over to you, Sridhar sir. Thank you. Thank you so much.
Thank you very much. Thanks a lot, everybody, for those kind words. I'm not sure I'm deserving of so many kind words. But anyway, I'll just start off the lecture. I hope you can see my screen.
Yes, yes.
Okay, so I'll just start off with a disclaimer to say that the lecture here, the lecture that you're going to hear is not an NNF guideline. It's more in the nature of a general guidance. And sepsis is a variable entity. And so therefore, all the points that I'm making during this talk may not be applicable to all the units. And some of these are things that I do in my unit. So it is left to you to actually choose what would work in your unit also. Okay. I actually learned today that just like exam papers being out, unfortunately, due to an error, I think my lecture was already uploaded into the LMS. So some of you would have actually heard or seen the video of the lecture, but still there are some differences to the live talk also. So basically, like I said in the thing, I'm starting the topic with rational practices to prevent late onset sepsis and NEC in the neonatal period. And this, you would agree, is slightly different from the way in which generally topics are, addressed. So normally you go through pathophysiology, you go through the clinical features, the methods of diagnosis, the treatment, and finally there is a small area of prevention. And somehow we are starting an entire course with prevention of late onset sepsis and NEC. And there is one major reason for this. You'd notice that many of your neonatal morbidities, like for example, RDS, MAS, over time, I don't think the pathophysiology has changed too much or the thing. It's just that with technological advances, you're having more tools to either understand the pathophysiology better or to have better treatment modalities. That's it. But otherwise, the disease remains what it was 60 years back, nearly remains the same today. Whereas sepsis is something different. I think Dr. Manoj also mentioned. Sepsis is a very, very variable disease. And it varies between units also. And it varies over time. And this is because of the changing profile of the bacteria producing different types of virulence genes, resistance genes, the antibiotics which are constantly changing over time and newer antibiotics which are coming into the pipeline, and also the host response which changes with the environment also, and our understanding of all of these things. And therefore, these keep changing over time. And the lecture that we give on these aspects today may not be the same that you will hear 5 years hence. And the only thing that possibly remains constant in sepsis are the general principles on how to prevent healthcare associated infections. And therefore, we thought that would be more important, and to start off the entire journey with prevention of late onset sepsis and NEC. Right. This, newborn are a vulnerable group and they are more prone to develop infections. And sepsis is generally supposed to account for 1/4 to 1/3 of all neonatal deaths. However, we have a major chunk of about 30%, 1/3 of babies who are actually classified as dying because of prematurity. But with advancing science, I know that many of you in tertiary care units will recognize that actually a large proportion of preterm do not die of prematurity related complications or prematurity related problems as happened, say, 2 or 3 decades earlier. But a large proportion of your preterms also die because of infection related complications. And if you actually put that chunk into sepsis, I think sepsis would account for nearly 40 or 50% of all neonatal deaths, especially in India. And it's by far the largest contributor to infant mortality. So my talk is going to address what practices can prevent late onset sepsis among newborn, what practices can prevent antimicrobial resistance among infected newborn and in the unit as such. And to a lesser extent, a small thing on what practices can prevent necrotizing enterocolitis. So all of you know this. The sources of infection maternal in the first 48 to 72 hours, what is called as early onset sepsis, is supposed to be the maternal environment. Though you would also know that many of the pathogens which were previously recognized as being nosocomially derived or healthcare associated infections now seem to occur, especially in India, earlier and earlier. That means at 24 to 48 hours itself, right? And it's a sort of a misconception that maternal infections only will contribute to early onset sepsis, and I'll address that as I come along. Okay, as I go along the lecture. And the non-maternal sources of infection will be through contact with an infected person or contaminated source, droplets, and airborne. Right. This is a very beautiful statement from Remington and Klein Infectious Diseases of the Fetus and Newborn, which says that most neonatal healthcare associated infections are caused by the infant's own flora. This seems like a very defensive statement, which means that I'm not responsible for anything that happens to the baby. The baby himself or herself is who is responsible for developing sepsis and dying. Is that the meaning of this statement? No. It's actually in some way, the newborn is colonized by certain flora, which then spread and cause sepsis. And this abnormal flora is derived from the mother and the NICU environment and the caregiver. And we are responsible for the latter two, and possibly to some extent to the first also. Okay, so we'll go to how these occur and what is going to happen. The other thing which all of you do recognize and which I have to address is the growing threat of drug-resistant infections in the newborn. And this is data which is adapted from the NEO-AMR Global Consortium, to which many neonatal units actually contributed their data. So you will see that of the deaths which occur from neonatal sepsis, India, unfortunately, seems to contribute the greatest number of deaths due to both gram-positive and gram-negative infection as compared to other LMIC in India and even China, which has an equivalent, if not more, population at that time to India. But in India, by far, had the largest group of number of deaths due to neonatal sepsis. And unfortunately, this was before 2016. You can notice that nearly half of the gram-negative bacteria were actually extended spectrum beta-lactam is producing. That means they were resistant to third-generation cephalosporin. And about a third of gram-negative cultures were actually carbapenem resistant. And this was nearly 10 years back. How has this evolved over time? Obviously, the situation is even more alarming now. Right. And one thing I forgot to say that in this AMR, the NEO-AMR study, about 30% of neonatal sepsis deaths were due to bacteria which were harboring an antimicrobial resistant gene. Right. Like I said, the ICMR produces this antimicrobial resistance report every year. And this is a wonderful actually document to read. Okay. And the susceptibility report in 2023 showed an alarming trend. It is actually makes very dismal reading. You can see that only about, less than 50% of E. coli isolates from all the ICMR reporting sites actually were sensitive to piperacillin tazobactam. And if you look at Klebsiella, the situation is even more alarming. 1/3 is sensitive to piptaz, just about above 1/3 is sensitive to meropenem, and less than 1/5 is sensitive to ciprofloxacin. Acinetobacter, the situation is even much more worse. Only 12% of Acinetobacter isolates in the country were sensitive to carbapenem. That means the majority of Acinetobacter were carbapenem resistant Acinetobacter infections. The one note of caution that I would like to tell you when you read something like the NEO-AMR report or the ICMR-AMR report, just remember that these are from data from generally tertiary care units throughout the country, and the ICMR-AMR data does not include only neonatal information. It includes information mostly from adult ICUs, and they're all from bigger hospitals and tertiary care. So when you read something like this, it should just alarm you to say that this situation should not occur in my unit or in my surrounding. But it doesn't mean that you should extrapolate this data and, for example, start treating any suspected Acinetobacter with colistin, etc., by extrapolating this data. Okay. So, and I was trying to see, does this mean that if we are running out of, the bacteria becoming resistant to carbapenems and piperacillin tazobactam, that means the beta-lactamase inhibitor, are we supposed to look for bigger and stronger and better antibiotics? Will we one day actually discover the ultimate antibiotic which will work against all bacteria and to which no bacteria will become resistant? Okay, this is a nice theory. It was a nice theoretical exercise also to do. And I actually looked at about 5 major antibiotics, and I was seeing when they were actually introduced into use and how quickly did these bacteria adapt to these organisms and become resistant. So if you look at meropenem, within 5 years of approval of meropenem, we started getting the first cases of meropenem resistance. Colistin, though it was introduced in 1947, came to, I think, great use after 2010 when metallo-beta-lactamases actually started proliferating throughout the world. And colistin started becoming used. And therefore, resistance occurred by 2015. Cefotaxime in about 8 years. The worst situation is with linezolid and more recently with ceftazidime-avibactam. You'd notice that within a year of introduction or approval of linezolid and ceftazidime-avibactam, bacteria have started developing resistance mechanisms. Therefore, we have to start off by acknowledging that bacteria are much more smarter than humans. We are never going to win this battle of actually discovering the ultimate antibiotic. Right. And that is also because many of your antibiotics that we are using are actually derived from bacteria or fungi itself, from actinomycetes, other bacteria and fungus. And therefore, inherently, most of the bacteria will have inherent resistance mechanisms against the neighboring bacteria like actinomycetes, etc. And therefore, it just needs usage or wide usage of this antibiotic for the bacteria to actually start activating these resistance mechanisms. And therefore, since we can never find the ultimate antibiotic, I think we have to look at actually trying to prevent sepsis and prevent antimicrobial resistance. And this is a very nice thing. By 2030 to 50, there are some estimates which says that we might actually run out of antibiotics. And so this might be the glimpse in 2050. I might be this old gentleman there. And the only way that we can get rid of bacteria is never with an antibiotic, but trying to beat a bacteria to death. And that is a situation, I think, which we should not get into. So let's start off. There are multiple or umpteen practices which can reduce healthcare associated infections and AMR. And it's almost impossible to actually cover each and every one of them within, say, 40 or 45 minutes. And therefore, I'm just concentrating on about 5 major issues. One, antibiotic use in mother and newborn. Blood culture practices, clean hands, clean procedures, and also care bundles. Design of nursery, though it does not come into the exact thing of rational practices, I always talk about it in HII, so I'll sort of briefly describe that. And the last thing is enteral feeding. Like I said, there are many more, and I think many of you will probably point that out in your chat, but we will concentrate on these during the period of the talk. The other things we can talk about either during the last panel discussion or the discussion after this lecture, right? So I'll start off with antibiotic use in mother and newborn. You'll notice that most lectures on sepsis or prevention of sepsis starts off with saying clean delivery room, right? Most of neonatal care, you always start off with maternal history and actually starting off with looking at the mother. And why do we not do this when we look at sepsis or sepsis prevention? Right. So, like I said, I'll start off with antibiotic use in mother and newborn. There is one misconception that if you keep, I had recently listened to a panel discussion on sepsis, especially I actually manage or care of extreme preterm babies, where one of the panelists actually said that they would not dare to stop antibiotics until this baby is off the ventilator and on full feeds. So the general concept, this seems to sometimes be a very popular concept, that if you cover a baby with antibiotic, the baby will not develop sepsis. And similarly, in the mother, there are many units I do know where any mother and every mother who's going to deliver, whether it's normal delivery or cesarean section, is actually given intrapartum antibiotics. So do antibiotics actually, when you give antibiotics during the time that the baby is on antibiotics, will it prevent sepsis, and will it prevent sepsis thereafter? So, but that's not so. This is a very great misconception, right? So this is a very beautiful pictorial. Okay, why do antibiotics increase the risk of later infection? Suppose you do have a colony or a community of bacteria. For example, bacteria which are colonizing the intestinal tract, right? The brown ones are the bacteria which are sensitive to this antibiotic here. The red ones you can see are actually having the plasmids which encode for the antimicrobial resistance gene against this antibiotic. And the white ones and the green ones are other groups of bacteria, the gram-positives or the fungi, which may not respond to this antibiotic. Suppose you do give an antibiotic, what happens is this antibiotic will wipe out the susceptible bacteria first. What is left now? The community now changes. Now the gut is colonized possibly with the bacteria which do not respond to this antibiotic, or the bacteria which have the resistance genes against this antibiotic. And these are now allowed to expand and proliferate. And therefore, you have an expansion, and the resistant bacteria now take over the niche, which was actually vacated by the bacteria which were sensitive to the antibiotic. And now you see that the gut is colonized with bacteria which are resistant to this antibiotic that you used. And these genes can then be vertically transferred. And the problem is that these resistant bacteria not only hold the resistant gene, but now start actually transferring these genes to the other bacteria which did not previously have the genes. So there is also a spread of the antimicrobial resistance gene. And this is what happens whether it's in the mother or the baby when we do give antibiotics. So, like I said, we'll start about antibiotic use in mother. It's rather surprising that there are many metagenomic and genomic studies looking at how the colonies of bacteria in the newborn or the microbiota of newborn change after antibiotic use in the early neonatal period. But surprisingly, it's only in the last 7 or 10 years that people have started looking, and this is throughout the world, on maternal use of antibiotics and how that affects the newborn microbiome. So looking at, it's not only the antibiotic which is transferred across and can directly change the fetal microbiome, but the antibiotic resistant strains can also go across the mother and baby axis and reach the baby, right? So acquired antibiotic resistance, are we born with it? right? And the last thing is looking at intrapartum antimicrobial prophylaxis, that is for GBS prophylaxis with ampicillin, and looking at antibiotic resistant genes in vaginally delivered full-term infants. What they all do say, or they actually conclude, is that maternal antibiotics will lead to transfer of the antibiotic to the newborn, and it will disrupt the fetal and the neonatal gut bacterial microbiota. And it will also lead to presence of more resistance genes in the newborn, which may persist through the neonatal period. So any infection which occurs in the newborn thereafter may be resistant to these antibiotics. So either ESBL producing or carbapenem producing, depending on what resistant genes the mother was harboring. And more alarmingly, these antimicrobial resistant genes may persist even up to 1 year. And therefore, if we start infection prevention with clean delivery, and the baby is already colonized with resistant genes, we have already lost the battle. Whatever we do thereafter, a colonized baby who has, for example, feeding intolerance or NEC is going to have sepsis with resistant organisms. And therefore, we have to start talking to the obstetrician. This, just like in other aspects of neonatal care, also depends on a multidisciplinary and a multi-team approach. Talk to your obstetrician. Ask them and request them to limit the number of antibiotics that they give to the mother, and give it for only conditions where antibiotics are indicated in the mother, and as simple antibiotics as possible. So maybe for chorioamnionitis, maybe for intrapartum antibiotic prophylaxis if the mother is GBS positive or if the mother has an UTI, but not for any and every condition. So this is very important. Next thing is antibiotic use in newborn. So you would notice, I think many people thereafter, Dr. Ramesh Agarwal and Dr. Tejo Pratap will actually talk about antibiotic stewardship. I'll just concentrate two things on right drug and right duration, two aspects of the AMS. How do you choose your empiric antibiotic? Will that impact infection prevention or antibiotic resistance? And right duration, will the duration of antibiotics matter in infection prevention? I'll just touch upon these two topics. For the first topic, I actually like one very, I'll just start off with a NEO-OPS observational study. This again is a study done in many countries and many units in India also, and by the WHO and the GARDP. And you'll notice that the initial regimen for sepsis in the first 48 hours of admission range from very simple ampicillin gentamicin to third generation cephalosporins and even to meropenem, right? And these are empiric antibiotics. And these are studies which show newborn exposure to antibiotics in about a systematic review of 4,000 neonates, and what is the resistance that it produces. So both infection and colonization with either ESBL producing Enterobacteriaceae, okay, or MDR producing Enterobacter cloacae, up to carbapenem resistant Acinetobacter baumannii may be caused by early exposure. That means in the first 5 or 7 days of life of the newborn to high antibiotics. Right. At this time, it's very nice to talk about the AWARE classification. This is a very apt time. I don't know, some of you may have listened to my lecture previously. Are you aware of AWARE? This is AWARE is the classification of antibiotics by the WHO. A is for access drugs, WA is for watch drugs, and RE is for reserve drugs. Right. So WHO actually classifies something, and as the name suggests, access drugs, this is very aptly named. So they say that access drugs should be widely available. That means they should be accessible, affordable, and they should have activity against a wide range of commonly encountered susceptible pathogens. And why these are very recommended as first-line antibiotics is because they show a lower resistance potential than antibiotics in the watch and reserve groups. And you'll notice that the antibiotics here are amikacin, ampicillin, penicillin, first-generation cephalosporins, and gentamicin. And these are, and cloxacillin. These are the antibiotics which are used in the newborn generally, along with metronidazole. So it will be ideal to use access group of antibiotics as first choice or second choice empirical treatment. The next is the watch group. WHO says that these are antibiotics that are at relatively high risk of selection of bacterial resistance. That means if you use these antibiotics as empiric antibiotics in your unit, you're more likely to have proliferation of drug-resistant bacteria in your unit. So you can use it as empiric first choice or second choice, but they would be second thing as compared to access drugs. And these include third generation cephalosporins like cefotaxime, ceftazidime, ceftriaxone, ciprofloxacin, carbapenems like meropenem, piperacillin, tazobactam, and vancomycin. And the last is something called the reserve group. Reserve group, WHO says they should be reserved for treatment of confirmed or suspected infections due to multi-drug resistant organisms, and they should be last resort options. And they should be tailored to highly specific patients where all alternatives have failed or are not suitable. Basically, they have a high potential for developing resistance. Therefore, they should be used only when you get a positive culture where the organism is most likely sensitive only to these organisms. And these include ceftazidime avibactam, colistin, fosfomycin, which actually for newborn, maybe the use is just starting, linezolid, meropenem plus BLI combination, which is still not available in India, and polymyxin B. Right. Therefore, the message will be use access group of drugs as common empiric therapy, restrict the reserve group of drugs to culture positive sepsis with MDR bugs, and you should have restricted prescription rights for reserve group antibiotics. My pediatric ID head always keeps saying we missed the bus with linezolid and colistin. When we started using these drugs, everybody was allowed to prescribe these drugs. And therefore, we developed resistance against these drugs very, very quickly. And therefore, at least for ceftazidime avibactam and going forward to cefiderocol, meropenem, vaborbactam, and the other beta-lactamase inhibitors which are in the pipeline, I think we should have restricted prescription rights. And this should be, I think, a very major step. For example, in my hospital, though it's a huge hospital, only the senior consultants in pediatric ID and adult ID can give prescriptions for ceftazidime avibactam. So even if I have an E. coli which is sensitive to cefta avibactam, I have to request the pediatric ID head to actually give the prescription every day for this baby. And that, I think, should be one of the things that going forward, we should do for the restrict group of antibiotics. So like I said, with the choice of empiric antibiotics determine resistance, there's a beautiful study done in one hospital in the Netherlands in 2 NICUs. And in one of the NICUs, they use penicillin G and tobramycin as empiric antibiotics, and in the other, amoxicillin and cefotaxime. And after 6 months, they crossed over the antibiotics. They did rectal swabs weekly in all the babies in both the NICUs during their entire stay. Right? And this is how it happened. In the amoxicillin cefotaxime group, within about 6 weeks, you can notice that there has been colonization of not the babies just who were treated, but all the babies. Right? You can slowly see the colonization rates increasing of isolates of bacilli which are resistant to empiric antibiotic. That means this antibiotic, amoxicillin cefotaxime. And there is one isolate which is resistant to penicillin tobramycin, but sensitive to cefotaxime, amoxicillin. And the exact opposite occurs when penicillin tobramycin regimen was used, where many of the colonized bacteria were actually sensitive to penicillin tobramycin. And there are a few isolates which are resistant to penicillin tobramycin, but sensitive to amoxicillin. Cefotaxime. When the units crossed over, again, the unit which used amoxicillin cefotaxime, you can see the isolates of bacteria which are resistant to cefotaxime and amoxicillin. Basically, beta-lactamase producing bacteria actually started proliferating. So which means if you use cefotaxime, if you use amoxicillin in your unit, it's not only the individual baby for whom you use the third generation cephalosporin who will become resistant thereafter to this antibiotic, but it's likely that all the babies in your unit, if you use these as empiric antibiotics, will start harboring resistant genes. And this is going to be the thing. So how do you choose your empiric antibiotic? Preferably, like I said, from the access group. Just remember one thing. This principle might work very well if you're an inborn unit or a predominantly inborn unit. For an outborn unit, it may not be strictly, work this way because you might have babies who are already exposed to higher antibiotics. But those people who are working in inborn units should try to use antibiotics in the early neonatal period from the access group. And the general consensus is that it should be based on antibiogram of your unit. That means if you have the antibiogram susceptibility pattern in the previous 6 months or 1 year, and about 70% of the isolates were sensitive to certain bacteria or bacterial regimen, then you can use that as empiric antibiotic. But I always add one more rider to this. I also think that this should be based on the culture positivity rate of your unit. For example, my unit has a culture positivity rate of 1 to 2%. That means 90% of babies for whom I do a culture, the culture is actually negative. So they either do not have sepsis or they have sepsis which is culture negative, which might be 2 to 3 times the number of culture positive sepsis. Suppose I take these 2% of bacteria, calculate the antibiogram, and base my antibiotic regimen from the watch or the reserve group and start exposing 100 babies to this antibiotic as empiric therapy, I'm actually exposing 98 babies who did not have sepsis or who were culture negative to these higher antibiotics. And therefore, I'm putting them at risk for late onset sepsis. Therefore, if your culture positivity rate is 15%, 20%, I think we should very sensible to use the antibiogram exclusively to determine the empiric antibiotic. But if your culture positivity rates are very low, I think you should use something from access group and just try to some way, either clinically or using your lab measures, try to identify those babies who then turn out to be culture positive or who harbor bacteria which may be resistant to the access group, and try to identify them early and only hike up the antibiotics in those babies. Right. The next thing, like I said, will duration of antibiotic therapy affect LOS rates? There are many studies, observational studies this is from the NICHD data of more than 5,000 VLBW. These are from Europe, Africa, and Western Australia, where most of them has shown that prolonged antibiotics of greater than or equal to 5 days in the early neonatal period increase the risk of late onset sepsis, NEC, and or death. The only difference was the more recent NICHD data in 2019, which showed that prolonged duration of antibiotics was not associated with NEC and or death. But I think it's very sensible to take the majority and try to restrict your antibiotics to 3 days or less, and definitely not exceed 5 days. Right, we have talked about antibiotic use in mother and the newborn. We'll just move on to blood culture practices. Blood culture probably is the first and most important step in antimicrobial stewardship. In one of the recent talks that I was actually attending, I learned that I think a large proportion of our SNCUs, though they are mandated to do blood cultures, still do not or are not able to do blood cultures before starting antibiotics in newborn. Okay, the problem with not doing a blood culture is that you're not sure what is your rate of neonatal true sepsis, and so you're exposing all these babies to antibiotics, and if the baby deteriorates, you're hiking up the antibiotics without knowing again if this baby had sepsis, and you might rely on a biomarker which might be false positive, and therefore you are actually worsening the. So antimicrobial stewardship cannot work unless blood culture can be done. India did a great job of starting RT-PCR during the COVID pandemic in every small village and many small hospitals. I think as public health policy, everybody, or even as individuals who run hospitals or neonatal units, somehow we should make sure that blood culture is done mandatorily before starting antibiotics in all newborn. And even if we do not or cannot have blood culture in our unit, somehow make sure that blood culture are sent to a centralized lab before starting antibiotics. I think that is the vital step in antimicrobial stewardship. Liaise with the microbiologist. In many instances, we get bacteria which sound very weird and vague, and we do not know whether to treat it, not treat it, how many days, etc. Liaise with the microbiologist. Talk to them and be aware of contaminants. Do not treat unnecessary bugs with long duration antibiotics. For example, more recently, we have started getting growths, sometimes growth of Acinetobacter L. wufi. When we talk to our microbiologist, it sounds very, very ominous, Acinetobacter. But when you talk to our microbiologist, we learn that this is a soil contaminant and environmental pathogen. It can very, very occasionally cause human disease, but by and large, it will be a contaminant. The other contaminants which are very easy to know are Micrococcus, aerobic spore formers, Aerococci, alpha hemolytic streptococcus. Again, Pseudomonas stutzeri, though it sounds very weird, again, it's an environmental pathogen. It can be a contaminant in most instances. Okay, where in only immunocompromised host, it can actually cause disease. So try to talk to your microbiologist and see whether they are actual pathogens or contaminants and whether you need to treat them. And diphtheroids. And the two conditional contaminants will be Burkholderia cepacia and Coagulus negative staph. Coagulus negative staph in a preterm baby who has central lines or any invasive procedure, by all means treat it. Whereas if it's in a term baby in the first 2 days of life, where a baby did not have central lines, not many invasive procedures, it is very, very likely to be a contaminant. Coagulus negative staph is by far the largest group of contaminants that we grow in our blood culture. So try to talk to your microbiologist. Dr. Naveen will actually talk more in detail about blood culture. But like I said, believe your blood culture in a well baby and stop antibiotics by 48 to 72 hours. Know your contaminants. In a bacterial culture system, if there's growth after 72 hours, it's generally taken to be a contaminant. And if it's polymicrobial growths are generally not contaminants, except only if they're after abdominal pathology. That means if you have NEC and perforation, as you know, the gut actually colonizes different families of bacteria within the gut. So the small intestine will have Enterobacteriaceae, Enterococcus, Candida, group B streptococcus. So if there's a perforation, all of these will translocate and you are likely to get a polymicrobial culture. So if it is after an abdominal pathology, possibly take it as significant, but otherwise, generally they are contaminants. So we've talked about antibiotic use, blood culture. We'll talk about clean hands, clean procedures. All of you know this, the WHO dictum or the mandate of 5 moments for hand hygiene. Before touching a patient, before clean procedure, after body fluid exposure, after touching a patient, after touching patient surroundings. But I always keep thinking that they have missed one very important point. Most of us do follow this in our NICUs, but this is something that the WHO did not specifically mention. And to illustrate that, I'll actually talk about another beautiful study. Right? This was a study done to see how bacteria actually transmit within a nursery. As a surrogate for the bacteria, they actually used a cauliflower promoter DNA. They placed this DNA on the telephone handle of, they had 6 NICU pods in their nursery. They placed it on the telephone handle of one of the NICU pods. And they collected samples at regular intervals up to 7 days and did PCR on these samples from various places. And if you look at this is actually very interesting to see that in more than 70% of the cases, within 4 hours of the DNA being placed on a telephone handle, the DNA was actually isolated from the chart of the baby, from the bedside of the baby, from the hands of the caregivers, the equipment, and the doors. And when they looked at non-patient areas, all of you will not be very surprised to know that the doctor's area, the MD area, was the one which was more than 80% or 90% colonized within about 4 hours. All the doctors' areas were colonized with this DNA bacteria, not so much the nurses. So you can understand that doctors, unfortunately, generally are the more careless people in looking at hand hygiene, etc. And in the break room and locker room. And also this bacteria was isolated in the other NICU pods apart from this NICU pod. Therefore, one of the very important things is you should remember, always wash hands when you enter the NICU, even if you do not touch the newborn. Why I'm saying this is, you'll notice that many people who are not involved in the care of the baby will keep entering your NICU at various times, right? This might include other neonatologists or neonatal care staff, and also other teams like pediatric surgery teams, the cardiology teams, the cardiothoracic teams, the therapists, etc. Generally, sometimes you'll notice that the person who touches the baby will wash their hands, whereas the others will not wash their hands because they are not actually touching the baby. And imagine that one of their hands, after touching their footwear, is contaminated with the bacteria, but they will come in the nursery, and during the nursery, if they get a call, they will actually use your telephone to make a call. They will actually use your computer to actually look at the digital x-rays, etc. If their hand was harboring the bacteria and they touch the telephone handle or the computer keyboard, by the mechanism that I previously described, within a short time, even if we do wash our hands, we are likely to take these bacteria and transmit it to the baby's chart, the bedside, and the baby. Therefore, everybody who enters the nursery should wash their hands. And this should actually be the 6th moment of hand washing for any NICU. There's something called aseptic non-touch technique. And this encompasses correct hand hygiene principles. And there's something called protecting key parts at all times during procedure using non-touch technique and standardization of procedures. A key part in this is described as those parts or sites that, if contaminated microorganisms, will increase the risk of infection. In IV therapy, this will be the parts of the equipment which will come into direct contact with either the infusion or the patient, right? The principle in aseptic non-touch technique is that you cannot infect a key part if it is not touched. That means even if you wash your hand, you should not touch any of the key parts which are identified during any procedure. And any key part must only come in contact with other key parts. For example, the syringe tip, which you're going to give an infusion or an injection in, is a key part. And that has to come only in contact with the needle hub. It cannot come into contact with the skin of the baby or with your hands. And non-key parts like the side of the syringe can be touched with confidence. So basically what we have to do is identify and educate the staff on key parts in all vital procedures like IV line insertion, blood sampling, intubation, NG tube insertion, etc. And tell the staff, educate the staff that these are key parts you're not supposed to touch. 2016 or 17, when we had an outbreak of Klebsiella, though we tried various methods to try to break the outbreak, nothing worked. So finally, we did a nearly one-to-one education of all the staff in the nursery and all the doctors on hand hygiene and aseptic non-touch technique, my colleague and I. And then we would go at regular intervals and see the compliance to both. Within about 1 to 1.5 months, the Klebsiella outbreak stopped. So these two are really, really vital procedures. So these are the key parts. For example, the baby skin. Once you've cleaned the baby skin, before you poke the cannula, you cannot again touch the baby skin to palpate for the vein. That is a key part. Only the cannula tip has to come into contact with the baby skin. The syringe tip, the cannula tip, the needle, vacutainer needle, bionectar connector, etc. So try to see if you can make, at least for the nursing staff, try to make simple thing for every single procedure, identifying the key parts. And then the care bundles. I'm not going to go into great details on care bundles, but it will be good to have central line CLABSI, that is central line associated bloodstream infection bundles, and ventilator associated pneumonia bundles. Very briefly, I'll talk about CLABSI. There is one systematic review which was published in 2018 of 24 studies, 5 observational and 19 before and after, which showed a significant reduction of CLABSI with care bundles, up to 60% reduction. What did most of these encompass? Maximal standard barrier procedures. That means proper gowning, proper gloving, etc. And actually training, education and training, audits and feedback, and checklists. Most of these studies actually had these 4 components. The others, which were actually in many of these studies, not all of them, were skin preparation and daily line need assessment. That means see whether this line is needed and pull it out as quick as possible. And then scrubbing the hub and having a centralized trolley kit. So it's good to see whether you can have a CLABSI bundle and have a checklist for checking whether you are following these procedures. So we've talked about antibiotic use, blood culture, clean hands, clean procedures, and care bundles. And the design of nursery, like I said, though it's not a practice, I thought because there are criteria for design of the nursery, I'll actually emphasize a few of these. When you have a nursery, the floor should be easily cleanable. There should be no small tiles. There should be minimal junction between the tiles because dirt will accumulate within the tiles, and dirt is one of the important thing of infections. And especially things like, for example, Serratia can actually proliferate in the dirt between tiles. Wash basins should be wide and deep to avoid spillage because one of the major things within a nursery is wetness. So there should not be splashing. Bed should be at least 3 feet away from the wash basin. Space for each newborn should be 120 square feet, which is quite difficult, I think, in most neonatal nurseries. My nursery definitely does not have this. We are fairly crowded. And if you're centrally air conditioned, there should be at least 6 air exchanges per hour. Right. So we've talked about all these 4, and we'll lastly come to enteral feeding. Enteral feeding, the 2 major and definite components should be try to get mother's own milk. right? And that's an essential thing in entire newborn care and especially for prevention of sepsis. And the other thing I'll emphasize the early total enteral nutrition. Okay, this has actually in the last decade especially come into vogue, and this was a study done by Dr. Sushma Nangia and team in Delhi, and this is a nice study, a before and after study. I think in 2010 and 11, looking at VLBW babies between 28 and 34 weeks, they had 3 phases. In the first phase, just like all of us do in VLBW babies, all the babies were started on IV fluids. Phase 2, they were started on what is called as early total enteral nutrition. That means 80 ml per kg of milk. That was either the mother's own milk or preterm formula at that time. At that time, they did not have a breast milk bank. Right. And the third thing looking phase 3 was sustenance, and they had more than 200 babies in the entire study. And you can see the thing, you can see the rates of NEC falling from 14% to 4%, and clinical sepsis from 90% down to 23%, and culture proven sepsis also showing a drastic change. Right. And there was a systematic review also, though, all looking at 4 studies, all of them from India, though the numbers were actually small, 4 RCTs. Though they did show a trend towards reduction of sepsis, it was not statistically significant. But I think in many units in India, especially secondary units, where the facilities or the personnel to actually insert IV lines very confidently or maintain IV lines is actually lacking. I think this is one of the things that we should try to see whether we can adopt early total enteral feeding. It's been proven to not cause more feeding intolerance or NEC. The other thing that I should point out is all of these studies, none of these studies had sepsis as the primary outcome. They were usually looking at feeding intolerance, time to reach full feeds or NEC. And therefore, it will be maybe good to do studies looking at sepsis as an outcome with early total enteral nutrition, or do QI studies having ETN as one of the component and definitely see if it reduces I think this should be one of the things which sounds very encouraging, and I think many of us should try to adopt this practice. So QIs, what can we do with this information? QIs to improve breastfeeding and mother's own milk and early total enteral nutrition. Like I said, I'll briefly talk about prevention of NEC. There were many QIs looking at prevention of NEC, and these were very large thing from hospital consortia in the US and and one from the Canadian Pediatric Network involving more than 50,000 babies. All of these QIs had essential component in all of the QIs was early human milk feeding, either with mother's own milk or with pasteurized donor human milk and mother's own milk. So definitely human milk feeding is the component which should be used for prevention of NEC. 2 of these actually looked at restricted medications as components of the QIs, especially H2 blockers and steroids, and having central line bundles. And I think 1 or 2 of them had shorter duration of antibiotics. I earlier mentioned also that early antibiotic use of less than 5 days definitely is proven in many observational studies to reduce NEC and hand hygiene. Right. So a very short again thing on prevention of fungal infections in the NICU. This is a very nice thing from Dr. David Isaac's evidence-based neonatal infections. Minimum duration of endotracheal intubation, minimum duration of parenteral nutrition or early enteral feeds, minimum duration of central venous catheters, avoid use of H2 blockers and use prophylactic antifungals, especially if the rates of fungal sepsis in your unit is greater than 1% of all admissions, or if you have very high risk newborn. Some the CDC and AAP actually do categorize newborn into very high risk, and low risk of developing fungal sepsis. So the other things which have been proven are minimum duration of antibiotics, like I emphasized earlier. Reduce the use of broad spectrum antibiotics, especially third generation cephalosporins and carbapenems. And lastly, avoid use of postnatal corticosteroids if possible. So in conclusion, I think that was quite a long lecture. Always do blood cultures. Again, I'll emphasize, I think this should be the pillar on which antimicrobial stewardship should be based on, as well as our thing to reduce resistant infections. Liaise with the obstetrician to rationalize maternal antibiotic exposure. Try to use access antibiotics as empiric therapy, especially if you're an inborn unit. Hand hygiene and ANTT are very vital. try to see if you can have care bundles to prevent healthcare associated infections, and mom and enteral feeding should be emphasized. These are very nice things, especially evidence-based neonatal infections by David Isaacs is a wonderful book. And then the ICMR AMR report again is worth reading, and critically important antibiotics by WHO. I'll stop with that. Thank you very much.
Thank you, Dr. Sridhar, for your beautiful lecture. And there are quite a lot of questions have come up. But let me just put a few to you first. Is that okay with you, Dr. Sridhar?
Sure.
Yeah, okay.
Sure.
So first question is, are we justified to start lowered antibiotic when we already know the mothers who are coming have received higher generation antibiotic, and our antibiogram in the hospital last 6 months shows resistant to all the common antibiotics?
Yeah. So, like I said, if we are looking at early onset sepsis, like I said, it is possible that the baby will be colonized. If the mother received higher antibiotics, it's likely that the baby may be colonized with, bacteria which are resistant to these antibiotics. But early onset sepsis possibly may be something which colonizes the mother's reproductive tract. And these, when I say colonized in the mother, it is generally, I'm talking about gut colonization, right? And that is the gut microbiome generally. So I would still think that for early onset sepsis, you should try to use your access antibiotics based on the bacteria which have grown in your unit over maybe the past 6 months or so. Okay, like I said, like I again emphasized, you will have a thing. See, we are a tertiary care unit and we get fairly sick mothers. Some of these or many of these mothers are exposed to higher antibiotics, but still our early onset sepsis is because of group B streptococcus and sometimes Klebsiella and E. coli. So we try to sort of rationalize and we still use penicillin and gentamicin. I still think that should be the way to go. Like I said, look at what your bacteria have grown, look at the antimicrobial resistance and see what is your culture positivity rate and make an informed decision based on that, not just on the basis of the mother having received antibiotics.
That's great, sir. And kind of similar questions that partially treated babies who are coming from outside and already received higher generation of antibiotic. Are we justified to start with a lower generation with a blood culture?
Yeah. The thing is, I think next week, Dr. Tejo Pratap is actually going to talk exclusively on this. He's going to talk about diagnosis of sepsis and meningitis in a baby in they are exposed to antibiotics and their management. So I think I will not step into his territory. So I will
Thank
just
you,
leave
sir.
it at the moment. So
Okay.
please, I think we will
So
address this in the next week.
Sure. One more question, sir. If sepsis screen is positive and the blood culture is negative,
Yeah.
what to do? And how
Yeah.
are we relying on our neonatal sepsis screen?
Again, I'm sorry, I'll just go to thing because next week, the thing is that if you have looked at the topics which are given, next week is actually blood culture and its uses and use and misuse of biomarkers. Okay, and that will include your sepsis screen, etc. So I think we'll possibly address this topic in the next week.
Next week.
So if there's anything on prevention, I think can be.
Okay. Sir, the one interesting question, the scrub, gowning, cap, mask, are they really necessary for an ICU?
No. So there is a Cochrane thing that was actually fairly old Cochrane also. The studies have also been done maybe 20 years back, which shows that gowning in no way changes your rates of late onset sepsis. Matter of fact, there is a small evidence to say that gowning may actually increase the rate of death in the NICU. Okay, so gowning, I don't think there is any evidence to say that gowning in any way reduces the rate of infections. Matter of fact, even changing your footwear has not been shown to prevent sepsis.
Okay. So, Dr. Tanushree, we have
To
any
reduce
questions?
infections.
So
We do think so. Gowning and And that is part of the infection. I mean, that's part of the contact isolation procedures, but otherwise gowning has not been proven to reduce or prevent infections.
Thank you. Thank you so much, sir. I think there are so important points, take-home messages from your talk today, like the global problem of AMR, the sixth point of the hand hygiene, that washing the hand, whoever is entering the NICU. So I think that's so important that we should do every time. So importance of the enteral feeding and how important it is. Most of the questions has been taken already, but there are still few, like Dr. Lakshmi has asked, like if the mother is an asymptomatic UTI mother, so does it need a treatment? And what is the most common cause of preterm onset of labor in India? Is it infection in the mother?
Yeah. Preterm labor, I think if we can establish what is the cause of preterm labor, I think we are very likely to get the Nobel Prize or thing. I really don't know whether we'll be able to establish the cause for preterm labor. I think that is one of the topics which will never get resolved possibly. So I'm not sure. There was one study, I don't know, I'll just put it out there, where they, in Africa, where they tried to see whether the organisms causing bacterial vaginosis would precipitate preterm labor. And therefore, they did an RCT where they gave antibiotics against the organisms causing BV by 24 to 25 weeks versus the other group not receiving antibiotics. It made no difference to the preterm labor rates between the two groups. So either the organisms which were causing preterm labor were not the same which were causing bacterial vaginosis, or the infection was not the one which was causing preterm labor. Having said that, all of you do know that there are things saying even remote infections like periodontal infections may precipitate preterm labor and therefore have to be treated with antibiotics. So I don't know what the exact thing would be. Infections, if they are there, have to be treated with the thing that it's possible that they may cause labor, but I don't know whether they will be the singular cause of labor. The other thing about asymptomatic bacteriuria, I think obstetricians also have differing thing. For example, if you have asymptomatic bacteriuria with, for example, group B streptococcus, the thing is that vaginal colonization of group B streptococcus, if there is a heavy density of colonization, it actually will enter the urinary tract. So if you have a UTI, even if it's asymptomatic and if the urine grows GPS, it indirectly means that the mother is actually colonized with group B streptococcus. So you do need to treat that and also give intrapartum antibiotic prophylaxis to the mother. So again, that will depend on the organism and depend on the obstetrician. Group B streptococcus, definitely, I think asymptomatic bacteriuria has to be treated.
So there is another one of the common dilemma that what we see, in case the blood culture resistance is to the empirical regimen is there, but the BB is clinically improving. So is it necessary to revise our empirical antibiotic choice, or we can wait?
I don't know the answer to this. I truly do not know the answer to this. To be very safe, I think we should revise the thing. But you will notice in practice, so I've been practicing neonatology for 28 years. I think every one of you, Dr. Manoj, also would have practiced for more than thing. I think all of you will have experience. So I think on a case-by-case basis, we sort of look at the bacteria and things. So I'm really not sure what the answer would be. Generally, the thing is try to believe your blood culture. But having said that, there is a difference between in vivo and in vitro sensitivity. I think if you talk to a microbiologist, especially for antibiotic combinations and for antifungals, they'll say that there is a very great disconnect between the in vitro sensitivity and the in vivo sensitivity. So I don't know. I have actually continued the same antibiotics. Sometimes we have changed it, especially when the bacteria is a very severe pathogen also. I'm not sure, or I don't know whether there is a right answer to this. I think next week when Dr. Naveen comes, we shall revisit this question and we shall see what the thing is. If anybody else has any other opinion also they can put forward. Dr. Tanushree and Dr. Manoj, anybody can also.
It's again one of the thing where there is a lot of difference between science and practice or something like that, you can say. So
Yes.
probably 50% of time, personally ask me, I continue, 50% I change or something like that, if you want to take this thing. So
correct.
not
remember one thing, I mean, just to remember one thing, that if there is something and the baby has an adverse outcome, then this will be one of the points which will be highlighted. So that you have to keep it in mind, especially in today's day and age, where there is this always this Damocles sword hanging over our heads of a legal issue also. So unfortunately, whatever is documented as results will be the ones which will be believed in from a legal perspective. So that is there. You have to keep that in mind.
Yes, sir. Yes. So maybe how sick is the baby and how much resistance
Also
that
true.
antibiotic.
Like I said, very
Clinically,
true. Very
yeah.
true. Like I said, conditionally, we on a case-by-case basis, we might choose to do either of these. And I have chosen to do either of these.
So another thing from blood culture, Dr. Thomas has asked, like if the baby is responding to the antibiotic treatment, are
Again,
repeat blood culture required?
Can I please ask him to wait till
Okay.
Dr. Naveen Jain's half the talk is on blood culture and on sepsis screen and other biomarkers. So anything to do with that, I think they can actually, it'll be good. They can wait. I'm sure that Naveen will give the answer during this talk itself. If not, they can actually visit that answer.
So Dr. Vinod has asked for your like any role of probiotics in prevention of sepsis. Your take on.
See, the thing is, there are two things that I did not, or maybe consciously did not actually talk about here. One is kangaroo mother care. Okay, so some or many of you would have read the systematic review by Dr. Sindhu and Dr. Jiva Shankar fairly recently, and that showed that a huge number of studies, more than 15,000 babies, it showed that use of kangaroo mother care reduced mortality, but did not reduced. There was a trend. It reduced sepsis less. There was a 15% reduction in sepsis, but moderate grade evidence. There have been Cochrane reviews, and there is a huge study from the Canadian Pediatric Network, which was published in January of this year in Pediatrics, right? Looking at probiotics. So this was a retrospective study between 2016 and 22 from the Canadian Pediatric Network. And they proved that, in that study, they said there is a decreased mortality with an odds ratio of 0.62, but there was no change in mortality, but there was no change in late onset sepsis or NEC. And in ELBW, there was decreased mortality with an OR of 0.58, but again, no change in late onset sepsis or NEC. In this same thing of pediatrics, actually, Dr. Roger Sol and Dr. Erika Edwards have actually written a very beautiful commentary also, actually justifying why, in spite of all this data, American Academy of Pediatrics still does not endorse probiotics. So they say that probiotics, if you have to use a biologic product, it has to be safe, pure, and potent, and manufactured in a way that these three can be guaranteed: safe, pure, and potent. At the moment, you cannot assure that any single probiotic or probiotic combination is either safe or potent or pure. So AAP, I think even in spite of this thing, they are sounding a note of caution. And the other thing is there are growing reports of probiotic sepsis. Previously, these could not be detected. So even in this Canadian study in pediatrics, 47 babies out of about 15,000 babies who were exposed to probiotics developed probiotic sepsis, and 4 of them died. Okay, so personally, I don't know. I do not use probiotics in my unit. My unit rate of late onset sepsis is about 1 to 2 per 1,000 live births. I don't use it. I know that people do use it. There is some evidence to say it might work, but still there is no clear thing on which probiotic will be efficient because each study has used a different thing. Actually, the Cochrane also mentions that there is biological heterogeneity. Biological heterogeneity. That means different probiotics, different combinations have been used, but there is not statistical heterogeneity between the studies. And this discrepancy is slightly not good. So we do not know which probiotic will work or probiotic combination will work. So I'm not sure, at least I would not put it as thing. And that's
So
one
you
of
are
the
not
reasons I did
using,
not.
you are not
indulge
using
on
in
this.
your unit.
Sorry?
You are not using in your
No,
unit.
we do not use probiotics in our unit.
So, sir, your take on HEPA filters in NICU. So, one doctor has asked.
Yeah. So, frankly speaking, I do not know the evidence for that. We use HEPA filters in our unit for, preparing IV fluids and total parenteral nutrition. So, I
Sir,
think there must be evidence, but I truly speaking, I have not looked for evidence that HEPA filters will work. It seems common sense or whatever it is, so I haven't. We use it.
so another question on early total enteral nutrition. Like we all know that mom's own milk is best, but is there any role of preterm formula if we are not getting that for the
Like I said,
weight?
yes, like I said, the study that I quoted, the before and after study, they actually used mother's own milk, and where it was not available, they actually used preterm formula. But I think in the later RCTs where it has been done in India, I think Dr. Mamta Jaju has also done one of the RCTs, so she might be able to answer this better. I think they have used PDM and MOM also. So, like I said, that
Yes, sir.
first study
Yes, sir.
actually used preterm formula.
Yes, sir. So in our
Dr.
case
Mamta,
also,
one of the studies is your studies.
yes, sir. So
Yes, ma'am.
we actually used, in most of the cases, we tried to get mother's own milk, but where mother's own milk was not available, we used preterm formula. So
Okay. At that time,
almost
when you did the
initially
RCT, you did
day
not
one
have.
huh?
Sorry, you did not have PDM at that time when you did the study.
PDA. No,
Pasteurized donor milk.
no, sir.
No, you
So
were not. Okay.
we don't have that time. It
Sure.
started just now, 2 years back.
So yes, I don't know the thing, but yeah, early total and especially when if you have a breast milk bank or you have access to a thing, then I think this is something that I think is worth looking at.
So there is another question on your like which are the babies they should receive the prophylactic antifungal?
Yeah, so there are two things. One of the common sense or approach used to be if fungal infections constitute, occur in more than 1% of your nursery admissions. Okay, but I think if I'm correct, it's AAP or CDC actually characterizes as high risk group. That means babies below 750 grams and with various features. For them, below 750 grams, especially if the rates of your fungal infection is more than 5%. Where the rates will be more than 5%. There, in many instances, you use prophylactic antifungals. Between 750 to 1,000 grams, they are at moderate risk where the rate of fungal infection is less than 5%. So you use it only when you give third generation cephalosporin or carbapenem, or if there is a GI procedure, etc. So there is a thing of categorizing babies based on their birth weight or gestational age, putting them at high risk and in certain situations you do give. But if you want to give it across the board to all VLBW, then if your fungal infections constitute more than 1% of all admissions, not all positives, all admissions, then possibly fungal infections are a thing. I think there are various criteria, but these are the two that I usually look at to see whether a unit will require antifungal prophylaxis.
So it's another common thing that what are your thoughts on use of intralipid and sepsis? Like, does intralipid increases the sepsis rate?
Yeah, again, I think even SPGAN guidelines say there is no clear-cut evidence that intralipids will increase sepsis, but intralipids theoretically can affect neutrophil function and platelet function. So it is more like a a general practice, neonatologists will stop intralipids at least during that acute phase of sepsis for the first 48 hours. But following that, once they cross that acute critical phase of illness, then possibly start. You need calories, so then you can start TPing. We do start, and I think SPCAN says that at least 1.5 grams of intralipid you can.
So there are a lot of questions on
But I'm not
blood
sure that is an
cultures.
absolute contraindication throughout sepsis. Sorry.
Yeah. So there are a lot of questions on, I think, CRP, blood culture and
Yes,
everything.
please.
I think that
we
will
can address all those
we'll
next
just-
week. And even rational antibiotic, I mean, more thing of antibiotics, individual antibiotics, and antibiotic use for specific cases of sepsis meningitis, all of that will be dealt with next week.
Yeah. Doctor.
I think we have
say
covered most of
anything?
the questions, Tanushree. Yeah. So maybe Dr. Manoj to wrap up or something.
Thank you so much, sir. It was wonderful presentation. Thank you.
Thank you. I hope it was very, it was understandable, and I hope it was useful too. Thank you very much, everybody.
So thank you so much, Dr. Sridhar, Dr. Braja, and Dr. Tanushree. It was a wonderful session, a good way to begin this course. Now we meet again on 24th June for the session that Sridhar was now mentioning, diagnosis of sepsis, blood culture, use and interpretation, use and misuse of biomarkers, and all those. So all those doubts which are there will be answered at that point of time. So I think we will close today's session. Anybody in the faculty team wants to make any final comments? Otherwise, we can close.
Dr. Manoj, they will be, if there are further questions, they'll be putting it up, Dr. Abhay, in the WhatsApp group. And
Abhay, just explain the plan of how because interactions will never stop yet. Yeah.
Yeah,
Yes.
I will ask them to put in the WhatsApp group and then I will forward so that sir can answer.
Sure. Whatever is to do with prevention, I shall answer.
Okay.
Others, I will not impinge on Dr. Naveen's or Dr. Tejo Pratap's territory.
So once again, winding up, I would again request each and every one of you, please do interact, ask all the doubts, and then clear all the concepts. And the certification is done at the end. So please do attend the post-test. Then only you will be in the LMS, you will be able to go to the next lecture. That will be on 24th. After 24th, the second lecture will be available on NNF. But LMS, again, you need to do the post-test as well. So once again, from NNF side, thank you very much for attending today's session. We'll meet again on 24th.
Thank you.
Thank you, everyone.
Thank you, everybody.